Welcome, everybody. We'll give it about another minute just to make sure everybody can get through their technical difficulties. Silence is deafening. Okay, good afternoon, everybody, and welcome. This is session IC11, Navigating the Telehealth Landscape, a Supplier's Guide. My name is Jerry Dickerson, and I'll be moderating today's session, and will provide the CEU code at the end. Before we get started, please remember to mute yourself. Questions can be asked using the chat feature, and we'll respond to those questions at the end. So I'd like to give a warm welcome and turn this presentation over to Kyle Walker.
Thanks, Jerry, and thanks everybody for being with me today. As Jerry said, this is IC11. This is Navigating the Telehealth Landscape, a Supplier's Guide. Before we get going, there are a few disclosures I want each of you to know. One, I do work with the VGM group with HomeLink, its managed care arm. I am the vice chair of RESNA's PSB. I also sit on the development board. And then lastly, I help the University of Pittsburgh's MRT program as an advisory board member. Now, we were talking about this before it got started, and I'm going to give it a shot. So typically, I like to start my presentations with a joke. And if you've heard this one, please forgive me. I cannot hear if you're laughing, if you enjoyed it or not, but we're going to give it a go anyway. If anything, maybe to lighten up your day a little bit in light of the monotony of sitting behind our desks and monitors for a few days here. But again, for great education. So I heard a joke the other day. There's an elderly couple, and they were starting to have some memory loss per se, which is probably normal with age. It got to the point where it got a little extensive. So both of them decided to go to their doctor, their primary care physician. So he sat down with the doc, started telling him about the issues they've been having. And, before going through all these tests, he said, for the time being, for if anything important, just write it down. And they thought, yeah, that's agreeable. So a few days later, they're at home sitting in the living room in the evening. And the wife asked her husband to say, hey, could you go get me some ice cream, as they're watching this television show? And he said, absolutely. He's a good husband. So he goes in the kitchen, and as he's in the kitchen, he forgets what he went in there for. So a little while later, he comes out with some eggs and bacon, and the wife goes, honey, you forgot my toast. You didn't write it down. So anyway, that's the joke. I hope you enjoyed it. Yeah, those are the disclosures. We'll start into the presentation now. I always like to give the audience a little background of myself as well. I think it just helps connect the dots and give it a little more humanized in our virtual world, even though we are talking about telehealth today. So I'm married with 2 children. That's actually kind of an outdated picture. My son is actually taller than me now. If you've never met me in person, it's not saying a lot. I'm only about 5'7" if I get a good night's sleep. So, and my daughter is now 6, and every day she asks, how tall she is on my chest, and getting bigger every day. I live in Eastern Iowa. Yeah, that's where I'm at now in my home. I'd rather be in person at ISS, but in light of COVID precautions, I appreciate the precautions and being safe. But educationally wise, my undergraduate degree is from Iowa State University in kinesiology. I have a master's degree in healthcare administration. And before working with the managed care organization HomeLink, I worked within the post-acute division of a hospital-based DME. Most of my time was spent on the PM&R floor, working with clients from pediatrics to bariatrics, everywhere in between. And working in a smaller, operation, I had the privilege, and I say that seriously, but kind of jokingly too, from time to time, of doing a lot of it, and all of it probably not well, but obviously participate in a lot of the evaluations with clients, whether in clinics or in their home, working with repairs from electronics to motors and hardware to the authorizations through insurance, and helping with appeals and doing billing, and then transitioning to the managed care organization at HomeLink now for about 3 years. I oversaw all of our assistive technology teams that encompass traditional group health managed care plans, Medicare Advantage, Medicaids, as well as in our workers' comp, self-insured, and auto insurance lines, which any of you have any practice within that work comp space, it's interesting. We'll leave it at that. And now in my role and capacity, I help lead and develop some of our higher acuity service lines, including CRT still, but also prosthetics and orthotics, our post-acute care program, as well as our complex care model as well. So I'm going to segue now into our learning objectives. And there's really 4 main objectives here. I do hope that you get more than this out of it. And at the end of the day, my intent at the very least is to have each of you challenge the traditional, or I guess your mindset, right, on the traditional evaluation and provision process, and think more critically and ask, is there a better way to do this? Is there a better opportunity for the patient, for the clinician, for the physiatrist involved, for the family? That's my intent. So regardless of these actual objectives, which we know we have to structure a course like that, I want you to think critically about how do we do things better. As Jerry, I think, indicated earlier, I'd like if you could save your questions to the end, and I'll save about 10 minutes for Q&A. I've got my timer going. So if you do have any questions, and for whatever reason, if we can't answer them all there, I'm happy to connect with you at a later time and have some further discussions. So the 4 learning objectives today. One, just a basic understanding of the history and relevance of telehealth, which I know was already discussed on our keynote session this morning, as well as a couple other sessions already today. And it sounds like a theme, which is probably fitting in light of everything going on for ISS. Second one is, I want you to understand there's, at least from my perspective, several key elements in that decision-making process, and want to have you grasp those. Next is understand the 3 areas that telehealth can be used within CRT. And then at the very end, gain at least 2 resources to help your evaluation, if that's something you're looking into for your practice, whether a supplier, clinician, that you can help make those educated decisions. So we'll start with a little history first. Again, this course is primarily designed for the CRT provider, but I believe it'll actually be useful for the practitioner involved in the procurement and provision of this mobility equipment. In light of the global pandemic, as we know, as COVID-19, the traditional healthcare delivery model has been challenged to provide care in new and innovative ways aimed to keep people safe, while at the same time providing equally or better care. With the growth of virtual platforms, I believe an opportunity emerged in our complex rehab industry. In fact, nearly 20 years ago, and don't quote me on the exact time frame, but it's ballpark there, researchers at the University of Pittsburgh, who again put on this great conference, started actually investigating methods to conduct healthcare services remotely, trying to identify if care could be provided in non-traditional methods, and then analyze results to look for future implications. And just recently, over the last year or so, they've had several papers published on their latest findings. Fast forward now to 2019, which in hindsight is 2 years ago now, or 3 years ago, I guess. Our world's in turmoil, right? We're facing one of the deadliest pandemics our world's ever seen, at least in my lifetime. We as a world explored so many ways to live in a new normal society, and I say that seriously and jokingly. We socially distance ourselves. We donned masks, gowns, gloves, face shields. We tried to figure out how we triage these critically ill patients, while at the same time trying to figure out how to provide care to our already medically fragile clients with assistive tech needs. Over the past 20 years, technology has continued to advance at phenomenal rates in industries from agriculture to healthcare. And virtual platforms have been used for years now to connect people all around the world to conduct business and engage in social conversations. But in light of the public health emergency, we saw a tremendous emergence in the adoption of these services from entities in the healthcare sector. really trying to figure out how to provide care in this new world. And these services ranging, but not just all inclusive of physical medicine to mental health and many more beyond. In order to do that, Centers for Medicare and Medicaid Services, or CMS, if you're familiar with the US healthcare system, temporarily allowed remote or virtual services to be conducted on non-traditional platforms and by non-traditional practitioners, which allowed entities along the healthcare spectrum to explore and participate in telehealth services, of which stakeholders, including ourselves, practicing in the assistive technology realm. This allowance has remained, and I say that at least for the time being, but the proverbial cliff is on the horizon. If any of you are familiar with those policies, you know what I'm talking about. More and more questions have surfaced, such as, are these virtual services or modalities applicable to our clientele? Great question. If so, how the heck do you do it? That's maybe one of the biggest ones, right? And are there operational opportunities from these platforms? Yes, is my opinion. Many things must occur, I believe, in order for these modalities to continue to be a viable option, ranging from the continuance of insurance companies allowing for these methods. The patients still seeing value in these services, which anecdotally here now, they do. And then research, really, I think that's a big piece of it from my perspective that has yet to be compiled to evaluate the actual effectiveness of cares. Regardless of the billable services, though, in the United States, there are non-billable services that are potentially equally as exciting. And that's, again, my opinion. And those are in the forms of home and environment evaluations to service and repair. In fact, there are actually, depending upon your familiarity, some providers in our in the United States today utilizing these technologies, and they're showing great results. And these results are decreasing patients' downtime, increase in patient satisfaction, and then anecdotally, I think there's a pretty strong correlation though, decreasing their health risks and expenditures. I believe that as patients and providers continue to look for different or better ways to receive and provide care, telehealth may be just one of them. Companies from big insurers in the United States to small independent providers are invested in these platforms. And I believe this will be in time to overcome the trend hurdle, I say, to be a viable option for many healthcare services, not just in assistive tech. And I do believe, and I'm optimistic that that could be a standard of practice at someday. So just a little bit on the history and relevance here. I would like to now transition to the decisions tree. That's what this presentation is over the last couple of years, myself and some stakeholders have put together this decisions tree. And I know there's some others out there. This is my opinion and way to do it. But to give you an idea of how to evaluate if that client is applicable, if telehealth is applicable for that client. So the decision tree, I'm going to change my view here in just a second, has several main components, one of which is new equipment, replacement equipment, modifications, delivery and fitting, follow-up, and then service and repair. Now I want to say this document, okay, don't grill me, it's not perfect. At the very least, it's a start. And again, if I didn't say it earlier, this presentation, as well as the document I'm going to show you now, is available to download on the ISS portal, or the hub, if you will. So I'm going to change my screen. So give me just a second here. And there's a lot. So I'll forewarn you. It looks messy and complicated. And again, it's not perfect, but it's a start. So if you can't see it specifically in all the words, what they say, feel free to, again, download it and review it at a later time. If at anything, though, having this dialogue and educated on some of these opportunities is, I think, a great thing. So give me just a moment here. I'm going to share my screen. Okay, I'm sharing another screen now. I'll give it just a second, make sure it shows up. Okay, so first, what we're going to talk about are sections. Excuse me if you're seeing my face here. I'm going to look at my other screen because there's a lot going on in front of me. So you can see my cursor. I think it's probably delayed. We're going to talk about section 2 and section 3. So this is for new equipment and replacement equipment. Now, I can zoom in. We do miss a little bit when I do that. So essentially what it is evaluating, okay, we know the service requested is for new equipment or replacement equipment for that patient, okay? So that's where we're gonna go down these avenues here. Now you will see on this one particular, it says proceed to section 7. So if I slide over again at your leisure, there's section 7 over here, okay? That section 7 comes into play if you believe that an LCMP, licensed certified medical professional, needs to be involved, okay? But for the time being, we're just gonna go through it here. We'll stop there. Okay, so again, like I said, we've determined like this is for a new client or even a recurring client for new replacement equipment. I wanna say based upon the collaborative efforts between US Rehab, the CTF, NARTS, NCART, University of Pittsburgh, as well as probably other stakeholders, maybe some of you included, it's been actually recommended that a pre-screen call is a critical first step in this decision-making process. This pre-screen has, or I guess is already traditionally done, I think, in a lot of instances when an inquiry is received by you, the provider in this instance, again, that's what this is intended for, to identify the proper next steps based upon the information provided by the client. But we're going to take it just a few steps further. So in the pre-screen, at least in that conversation, again, dialogue back and forth, we should seek to understand the following. Obviously, the reason for the call, basic information, demographics, insurance information, obviously very important here, current equipment, right? And the data service, who is the provider, all this nitty gritty stuff, which you and I all probably know. Medical equipment pertaining to mobility, rehab, their MRADLs, right? Those qualifying questions. What care teams involved? Is the patient open to using telehealth? Again, that's the intent of this presentation. That's probably one of the key points on that pre-screen. Are they open to it? Next, you're going to say, do they or could they have access to that virtual platform? Again, a lot of emerging tech around those today. And then lastly, do you feel their care or their need can be assessed virtually? So from the pre-screen, we've determined if the client is a candidate for rehab equipment, or you may direct them to local, retail, medical, or other industry resources to help them meet their needs. If this is a returning client, you may already have much of this information, but as previously mentioned, I don't know if I did mention that or not, but I think it's important not to make any assumptions. And I felt guilty of this too. Many times in evaluations, questions have been asked, whether by myself or a therapist working in conjunction with me, which may provoke thoughts from that client, which may help direct the intervention or recommendation, sometimes maybe in a direction that it may not have originally gone. So my moral of that little tidbit is don't skip the small steps, ask the questions. So next, if you feel that their needs can't be assessed appropriately through virtual assessments based on several factors, you would proceed with your traditional provision process for complex rehab equipment. Taking consideration local, state, and federal disease prevention precautions. Again, our intent at this time is to determine if that client is a candidate for telehealth services. During the pre-screen, again, it's important or imperative that you determine if you feel either by situation or more often, probably by policy, there needs to be an involvement from an ATP. Again, based on CMS's LCDs, we know an ATP needs to be involved. The ATP requirement, again, depending upon your familiarity, may be dictated by that policy. But as a industry professional, you have the ability to make that decision if you feel that there does need to be involvement from that ATP. Again, the end of it needs to be the best outcome in mind for that client. Additionally, during the pre-screen, there's a lot about that, right? Need to determine if you feel either by situation or policy, there needs to be an LCMP, which we mentioned before. Again, LCMP is licensed certified medical professional. Remember from here, we've already determined that it's part of that process and we want to make sure that they have access to that virtual platform. Now, if you don't feel that LCMP needs to be involved and their medical need or request can be handled by appropriate medical professional, you can direct them to the proper next steps for even your organization to help facilitate this for them. So there are many opportunities currently with the expansion of virtual technology to create deeper, more meaningful relationships and even sooner to attain more effective documentation through the virtual platforms when traditionally we would have suffice with a phone call, right? I do believe that creativity is in your hands, especially when it comes to those non-billable services that we talked about: home evals, documentation, patient status updates, and follow-ups. Uh, and I do want to say this as we're going through this here today, that I think we would probably all agree, at least to some extent, that you simply cannot replace in-person meetings and being hands-on, right? It's just not the same. But given these historic events, and our ability to be creative during these times, I think you can be more effective with your money and your time. So again, let's go back to it. Sorry, there's a little tangent there. Let's say an LCMP does need to be involved. So you're going to have to now determine who's going to be present at home with that client. Okay. Is it you or the LCMP? You being the medical provider, supplier, right? Synonymous terms. When we're looking at that evaluation in home, which I'm sure there's probably a session on it already here, and I think I attended one earlier this morning from some VA folks, but it's important to understand what that looks like in the home, where we're doing those functional and objective tests, right? Such as those range of motion, manual muscle tests, ambulatory, propulsion, all those things, right? We need to understand how it's going to be conducted in the home. Care needs to be really taken to ensure the parties have the ability to participate on the same virtual platform. Okay. There's several entities in the marketplace that actually employ therapists specifically trained in providing telehealth that it may behoove you to explore. From there, we want to proceed to schedule the virtual assessment with the client and the LCMP. If possible, recommendation is to do a quick trial with the client and potentially LCMP if it's a new practitioner you're working with before the actual evaluation. Again, to work out any kinks and prepare the client for what to expect during the visit. Now, during the call, you want to address precautionary screening questions to ensure there's no symptoms that could present risk to care team, including yourself or the LCMP if they're in home, or depending upon who's going to be present. May be beneficial to have a even family or friend present if you're doing some different tests, again, for that support, right? At the virtual assessment, okay, now, before you begin, you have to ask, I'm saying you have to, again, this is still new for a lot of us. I believe care should be taken to ensure the following. Again, basic stuff though, but non-life threatening situation, basic precautions surrounding environments, location, privacy, verbal consent, and again, that this is going to be conducted in this manner as well as potentially recorded. At this time, again, forecasting here, depend upon your practice, it might be a great time to notify them of an outcome program if you have it in place post provision or after delivery. Okay. Now, after all that takes place after the remote evaluation, you want to be sure that it has been recorded and stored properly based upon HIPAA regulations. In the protocol, update your EMRs and continue to the next step. Again, this session is not aimed to say, okay, how do you do it in person? I am not a therapist, although I've worked very closely with a lot of therapists for a long time. The intent of this is to decide if that client is eligible or telehealth is applicable for their need. So the next section we're going to go to now is section 5 and 6. So if you can see my cursor, 5 and 6. Okay, so we are now looking at delivery and follow-up. Now we know there's a lot of red tape between there from authorizations, appeals, billing, all that kind of jazz, but we're going to look at the delivery and follow-up piece of it now. Okay, so after you receive the equipment, right, it's highly recommended you use qualifying documentation, potentially the ATP assessment, in conjunction with maybe the therapist notes to set up the equipment as best as possible before it leaves your doors. Your office, warehouse, or shop, whatever that looks like, is going to be the most controlled space you have. And I can't stress this enough. You will have virtually everything you need at your disposal there, right? Outside of that environment, you run the risk of having things outside of your control. These could be as simple as temperature. Jerry and I were talking before I hopped on this that the last few weeks in Eastern Iowa, it's been single digits or below. I do not want to be necessarily in someone's home or traveling or in my van at that time. It could be infection controls, all those kind of things. Again, work with what's in your control. Okay. My intent is to enable you guys to be as prepared and efficient going through that. Now, once it's been set up optimally without the client, right? It's highly recommended that you or a customer service rep connect the client to prepare them for the delivery of the equipment. Again, remember, we're looking at a virtual application of this, knowing that not everybody fits the framework, right? To be able to apply this. The pre-screening questions, right, related to infection risk. Now we're going to say we need to obtain the client's preferences. Do they really just prefer in-person or hands-on? Okay, or are they still open to doing something in a virtual method? Okay. If precautionary measures are currently in place, I've heard some providers can get pretty creative with the location of the delivery. Many providers like yourself have utilized open spaces like garages, parking lots, even porches separated by windows to mitigate that in close contact with the patient. I think you absolutely need to be clear on what the client should expect in terms of the duration and potentially with follow-up visits and who's going to be there. Let them know the standard precautions that you and your organization are taking to protect you and yourself. And really, you want to set their mind at ease. Now, my thought is that, and you might grill me for this, but not every piece of equipment needs to have in-person delivery. I say that tongue in cheek. I know we still would recommend, right, doing that, but I think there's some times that there are some equipment that maybe just needs minimal adjustments. Okay, such as, we'll use an example again. Not every situation is this, but a POV, right, scooter power operated vehicle. Okay, it could potentially be delivered to the doorstep or picked up from your office. I do believe that still within that, the care should be taken to ensure proper fit, function, education, patient satisfaction, right? I don't suggest or implore anybody to just drop ship that equipment, but being creative, I think we could do stuff and then virtual in to do some of that training and education if there's a need for that. Now, at the time of delivery, there's an acronym, and this is kind of gets off a little bit, but something that's important to me that we practice a lot when I was with the health system was an acronym named, or excuse me, called AIDET, AIDET, which stands for acknowledge, introduce, duration, explanation, and thank. Okay, so those 5 letters acknowledge, to acknowledge a person, make eye contact, right? Even if it's a virtual environment like you guys. I know my camera's up here. I want to look at the camera. I don't want to look at another screen while I'm engaging with this person over here. Introduce. I think there's a lot of validity to introducing yourself, who you are, maybe where you're from. I don't know how personal you want to get, but again, they set their mind at ease to know that their lives and mobility and accessibility in their environments are kind of in your hands. Duration's a big piece of it. Understanding what to expect for that time of the visit. Explanation, what's going to go on, from the setup and the methods, modalities. Lastly, this is one I don't think we can all forget, but to thank them, right? At the end of the day, most of us, there's probably quite a few of us practicing within a VA system or even maybe a nonprofit, but I think there's probably quite a few that are in a for-profit manner. And if they didn't come to you, you wouldn't be in business. So thanking them for choosing you. Now, at delivery, as aforementioned, I think there's many ways to be creative to maintain proper CDC practices, as well as provide, I guess, adjustments to the equipment effectively. Mitigating those close quarter contacts, I think is still very important, but understandably hard to manage, especially with patients that have those complex positioning needs. Proper PPE, which is, I believe, personal protective equipment. Apologize there. I think it's imperative that you don those different pieces of equipment to mitigate that risk. Now, after setup, typically as a CRT provider, you're going to have to show proof of delivery. Now, there also may be, and I'm not sure currently if there are temporary policies in place still, lifting that traditional need to have that signature. I know that there are some providers who've utilized methods like providing a free pen. Like, hey, good marketing opportunity, right? Utilizing a tablet to sign that you can clean and wipe down. And I think there's even some that have taken pictures as proof of delivery, or even an audio video and that they can store in the EMR. Again, you can be creative with some of those things. After the initial delivery and fitting has been complete, it's highly recommended and oftentimes I think required from a compliance platform or standpoint, excuse me, that you have to have a follow-up with that end user. Now, there's many ways and methods for this, from basic telephonic methods to simply asking how are things going. Can be a little more specific than that, but even maybe more sophisticated through mechanisms like the FMA. And if you're not familiar, the FMA stands for the Functional Mobility Assessment, and it's a collaborative effort between the U.S. Rehab, not the U.S. Rehab, and the University of Pittsburgh to ensure the appropriateness and effectiveness of equipment provided. Through the survey conducted by US Rehab, the data is collected and can be utilized for many different initiatives within your own organization, from compliance, effectiveness of cares, to marketing. Now, I think as we discussed, maybe I said it earlier, that I think the FMA and some of that data, and I'm not sure what Dr. Schmaler and Dr. Sheen are doing it as part of that, but to look at evaluating a baseline of traditional methods versus virtual methods and providing that equipment and those health related scores post provision. But I think that's something we definitely would recommend doing. So when conducting those formal follow-up calls to consumer, again, those topics ranging from what satisfaction, functionality, proper fit, concerns, again, it would behoove you to explore, can do this if you can do it virtually. Not only can you, the provider, be able to just talk to the consumer, on the phone, but I think we can do it a step further, right? Actually see them in their chair. Now, as a provider, sometimes I was privileged to do that, but the practitioner or the therapist, I don't think always. And I think it's really an opportunity to bring it full circle, where they, traditionally, we've only been done by me, the provider, not that LCMP. I think there's a silver lining here too, is better yet, I think that therapists now, and don't quote me on this, but I'm pretty confident that they can even bill insurance for their time. And there's even some emerging opportunities that a provider may actually, even a DME provider maybe, at time bill for this service. And that's a kind of a catchy thing now called remote patient monitoring, or RPM. So after that, I believe that we have a satisfied customer. You have a satisfied clinician and a referral source. You can rest easy knowing that your time and energy is well spent and that it's meaningful. I think it's a perfect trifecta. You provided amazing care, streamline the process, reduce the patient's health risk, and save your company time and money, all by challenging the status quo and using technology to your advantage. I'm gonna take a drink here before we move on to the last section. Okay, so this last section is in service repair and modification. I'm clicking along to my other PowerPoint slide, but since I've got the actual decisions tree up here, I'm not going to show you the other one. It'll take too much time. So again, service repair and modification. So we are looking at sections 1. I probably should have reordered this. Again, don't grill me on this. Section 1, service repair, modification is here. Okay, so 1 and 5. Let me scroll it up so you can see that a little bit. Okay, so again, upon determining what the request for service is, we've determined that it's for repairs, troubleshooting, or modifying the client's equipment. Okay, so again, this assumes that the client has contacted you with the request, and maybe this is a current client of yours and you already have updated insurance information, documentation, etc. Ideally, for the sake of time, energy, and cost, you would want to try to resolve this issue remotely. Again, that's my 2 cents, before investing into an in-person visit to the client's location. I do believe there's many reasons, from logistics to timeliness, exacerbation, it's a tough word for a Monday, of health risks to operational cost. But I think we can save that operational conversation for another day. I'm happy to have that further at some point. There are many methods, I believe, in platforms to conduct virtual assessments. But they can really be as basic as asking the right questions on the phone. Once you're connected, though, let's say on the virtual platform side, care should be taken again to ensure non-life-threatening situations, basic infection precautions, those kind of things, verbal consent, right? Again, standard practice, right? Do it the same time the same way every time. I do believe that there's much to be addressed as it pertains to following proper examination and testing protocols with power products specifically, as you relate that to maybe non-powered power, like manual chairs, K5s, E1161s. But again, those protocols should be per manufacturer training and recommendations. And this would be the right time to probably facilitate those questions, right? Going through that actually product specific decisions tree and asking what's going on. perhaps maybe through that questionnaire, you've determined that that issue is a simple joystick lockout, right? And you can now guide that patient through that process to unlock their chair. Perfect, right? Ideal. Problem solved. Basic training says you should ensure there's nothing else they need, right? Anything else I can do for you? And then you're going to document it in your EMR, right? Seriously, congratulations. Right there, then and there, you've saved your company time, money, hundreds, maybe arguably thousands of dollars in a quick 10-minute call. More importantly, and I don't want to, can't stress this enough, you've allowed that client, right, the patient, that's what we're here for today, is to go about their day living their life, not ours, their life. So again, supporting the way to do it virtually versus the traditional way. But let's back up. Maybe it wasn't quite that simple. Okay. But let's use a platform, Skype, I think, which they have a compliant platform. You're able to, again, connect with them, determine that the tread on the tires, on a power chair is faded. Both need to be replaced. That swing away joystick E1028, the mount's broken. And the seat elevation, I don't know if you have been, any of you on the call or any technicians, but it sounds like a popcorn machine. Probably needs to be replaced, right? Great. Guess what? Let's say that's all they need. Fabulous. You didn't have to go to their house, right? You successfully assessed the power chair for repairs from the convenience of your air conditioned, well, depending on where you're at in the country. For me, it'd be heated environment, right? In my office. Patient didn't have to wait a week and a half for your company's route, right? Didn't have to drive and wait for them to assess the repairs needed. Again, keyword, didn't have to wait to assess, okay, the repairs needed, okay? Now, again, you did it all in 20 minutes. Additionally, since you have that assessment, now you can order the parts if you don't have them in stock, saving additional time and money. Again, after that, you're going to document the repair assessment, thank them for their business, update your EMR. Yes, we know there's times that you can't address the issue remotely, but in my opinion, again, my opinion only, I believe it's worth the try. Okay. If that's the case that you can't address the issues remotely, you're going to facilitate the normal procedures to either have the client bring in their MAE. If you're not familiar with that acronym, it's mobility assistive equipment, right? It can encompass a lot of things. So you're going to bring it in or schedule time to do that in-person assessment. Again, always important to ask the questions that you think are routine, that you think you may already know. Ask them anyway. Again, don't skip the corners, right? For example, let's say that client or patient starts talking about progression of their condition, and now they have difficulty staying in that midline position to access their head array. Maybe time to consult the ATP and or clinical therapist, LCMP, for further assessment, right? Ask the questions. Again, be sure to follow your current local, state, and federal protocols pertaining to infectious disease precautions and methods. After all, we all know the population we work with, sometimes they're the most fragile, right? We want to keep their best interests and health in mind, as well as ours and our families. And I think it's a very valuable point as well. Now, similar to service and repairs, some modifications, again, some, not all, I believe can be initially assessed remotely, which let's discuss that a little bit. As I previously mentioned, again, it behooves all of us to start with asking what's happening, right? Why they're calling, what's going on. In this scenario, let's assume the client's contacted us. Okay, this is a current client. We've got all the contact info. We verified all that jazz. Okay, so you start asking questions to the patient. Be sure to keep a keen ear out for the responses that indicate you should involve the ATP or LCMP. Again, my perspective, challenging yourself is good, but we want to practice within our scope, right? As an ATP, if that's the role, or technician, right? And then engage those right professionals when it's needed. Okay. So let's imagine in this situation that a delivery technician forgot to tighten an Allen screw on the back of the collar on the headrest, right? And after a few days, the post sunk down into the receiver and it's not going to fit them anymore. If it's a head array, yeah, that's very important, right? When they're doing alternative drive controls, now they can't access their environment, can't drive to get around their environment. Okay. Now let's say you receive the call and it's that patient's daughter, whom through processes, HIPAA compliant stuff, you verified that could speak on behalf of the parent, okay, who is the client. But she wasn't 100% how to correct the issue, but she was bound and determined to do it herself. And you said, okay, let's figure this out. Now you could probably do it on the phone. It might be a little more difficult. So can we do it better? Yes. Okay. Actually, she might have even brought her Allen wrenches right from her little home repair kit. Okay. But just wasn't 100%. So you as a educated, competent ATP, technician, supplier, CSR, whatever that looks like, okay? You virtually inspect the headrest and receiver. Lo and behold, like we discussed, it's the collar. That's all it was. You walk her through those proper setups, step by step, make sure you have your checks, go from there. Again, I can't stress this enough. Saving time, money, resources. Update your EMR, you help the customer, you're on your way. Again, I think so powerful. Again, these traditionally even non-billable services that we know there's not a lot of money to be made in the service and repair industry. And can we do it better? You bet. Okay. Now, I understand it's not always going to be that easy. Just a couple examples. But again, I want to implore you guys to try. As I stated before, if you can't address it remotely, follow your normal precautions, right? And schedule the things in person, whether it's in your office or in the communities. At the end of the day, and I'm going to pause there. I'm going to stop sharing this screen and go back to my slides here. And let me share my screen one more time. Number one. Okay. So at the end of the day, what my intent for you guys is say, can we do this different? Can we do it better? Is that client qualified to do something virtual? And then can we address all the needs? And that's what I believe is a downfall to major, or excuse me, a lot of suppliers these days, is they're stuck in the traditional status quo. Getting out of that norm is, I believe, an area which change is hard for everybody, right? But with what we've seen in the adoption of telehealth services and the access to technology that we have, that we've historically never had in this capacity in the healthcare sector before, or if we haven't really tapped into it, I believe we would be doing not only ourselves, our colleagues, our business, but the clients a disservice. Again, ask the questions, can this be done more effectively to produce better results? The slide I've got showing now is just a few industry resources that I know have engaged in specific research, as well as support mechanisms for telehealth or virtual services. US Rehab being one, an affiliate of mine at the VGM group. University of Pittsburgh, who obviously a great organization and educational institution, putting on this wonderful a conference here this year. And the CTF, I know they've got decisions tree too. I think it's more geared toward the practitioner or the therapist. But again, a lot of different resources there. And I can be a resource as well. I'm not perfect. Again, my intent is make sure to challenge you guys to say, can we do this more effectively? Last, just have a slide of references. I'm not going to go through them all. We will recap the learning objectives. And I've got a little statement I wrote, and I'm going to read this one almost verbatim here. So bear with me for a second. In summation, as it goes in our industry, nothing's easy, and it can be sometimes downright complex, pun intended there. But there's an opportunity to challenge the traditional methods to provide care in non-traditional settings. I believe we're in an age where technology can be used advantageously for the sake of patient care as well as business operations. I think I almost said this exact little bit ago. Yes, there's much to still do to ensure the outcomes while using virtual methods are significant, but the data we have this far, including patient experience, is promising. And I implore you again to, at the very least, explore the possibilities, ask the questions. So we'll leave it at that. I appreciate your time today. I wrapped up a little earlier than I intended to. We've got about 5 more minutes till my 10-minute Q&A. So here is my contact info. And Jerry, if there are any questions, I'm going to stop my timer here. I'm happy to answer them now or at a later time. So
Can you hear me, Kyle?
Yep, gotcha.
All right, cool. Well, the first one is more of a statement. The joke was terrible.
Oh, geez. Well, my apologies.
That was for me.
Oh.
And then when you had your decision tree up, Linda Lunger just typed in "wow," which I would concur with. That looked like Medicare enterprise architecture. So that's why I asked you if you ever worked at Medicare.
Right. Well, I may say to that too, and I had mentioned it, but I would encourage anybody to download it. I put it into a PDF, and to be totally frank, I'm not trying to make a buck out of any of this. My intent is to take this, print it out. I don't know how many pages it would print out, maybe 2 in a landscape format, and go through it. See what's applicable to that, so your supplier's practice. I think there's things you're going to have to change. I did this through a lucid chart with some other colleagues. Again, shoot, it's probably been about a year ago now. But yeah, it looks like a lot. Once you go through it, it's the stuff you know. But again, it's asking those questions on to say, is telehealth appropriate for this client in this specific situation? So anyway, go ahead, Jerry.
Well, then there were no others. So in order to stimulate the conversation, I have some questions.
Okay.
And one of them is the discussion between telehealth and teleservices, where funding sources will look at telehealth interventions as something done by the LCMP or the
Sure.
medical community, and teleservices is done by the supply community. And so I wonder if you have any feedback on that kind of a delineation in the nomenclature on how we're looking at this going forward. And then I actually have a couple of more. So
yeah, no, that's a great question, and I use those terms interchangeably. Jerry, when you look at telehealth and the provision of actually healthcare services in that virtual environment, yes, that would be traditionally handled by the LCMP, right, or the PTOT, physiatrist, that actually medical professional. And I say that almost tongue in cheek because I hate undermining our industry, saying we're not medical professionals.
Right.
I feel we are, but again, from a policy standpoint, I think it's similar to years ago in the O&P field, which I get to help lead some of those initiatives at my organization. I think they might be a little ahead of us in terms of that nomenclature. So yes, to correct it, I guess if you want to say that, it'd be teleservice or virtual services practices. Dr. Schmaler and I talked about that the other day, and just for everybody's comfortability, I said telehealth. So
I just think it's important to delineate, because
absolutely.
In my marketplace, the advent of telehealth was a game changer during the height of the pandemic.
That's interesting you say that, and I having the privilege to speak with providers all across the country, from rural environments to, urban environments. Like Jerry, you said you're in Jersey and New York City practicing. Some providers, even prime COVID, I know we're still dealing with it, but never had to, which is okay. But still, I would even challenge them to say, can we do things more effectively, specifically in that service and repair side? I just think there's so much that's not tapped into in that perspective, Jerry.
Absolutely. And we won't go into that. I won't go into that whole, but I will challenge you on the events of being able to use telehealth as saving money, which is all great when this is all brand new. But I've done this for a little while now, and I would just tell you, at some point, it's an increased burden in the supply community that needs to be reimbursed. And I would fight back with any payer source that says to me, well, you're saving money by not having to go out. I would say to you, well, then why should I even go out at all if I'm not getting paid for it? We need to change the dynamic of service and repair, because it is just not paid for appropriately.
I don't disagree with you there. When you look at it from that perspective, that's a policy conversation. I would love to assist in those conversations, Jerry. Yep. And I will be advocate day in and day out with you or with any other stakeholder in that conversation with any payer any day.
Yep, it's got to be an academic discussion, because it's in order to treat people correctly, you have to have people that are paid appropriately, and we can continue to chase our tails round and round and around. What the problem is with service, the problem with service is money.
Well, I don't disagree. And, a lot of the research I'll use the FMA. It's one I'm familiar with. I know there's some other outcomes programs out there as well. I think that's a whole intent with it. And I think it's even the mantra for the conference here is showing our value. That's a huge piece of it, right? Yep. We have, and actually tomorrow I get a chance to speak on the keynote tomorrow about large data. And I'll just give you a little snippet into one of my talking points, but essentially, in our world, much of what we do is based upon policies and somebody else making decisions on how we practice, right? Yeah. At the end of the day, I hate saying it, but we're in a sales role. We have to be able to advocate for our industry and make them see why this is valuable. If it's a for the LCMP, or excuse me, LCD vernacular is paint the picture, right? Paint that clear picture, or monetize that to them. What does that mean? Too often, I get privileged to work with a lot of different insurers in different landscapes. And at the end of the day, it is what it is. It comes down to money, Jerry. And we have to be able to speak that and advocate why this is beneficial. I hate saying it like that, but it's a truth.
No, but it's the truth. That's what makes the world go round. It's a Jerry Maguire principle, and it's not a bad thing.
Right.
You if you have money, you can provide more services. If you're getting paid appropriately, you can provide more services. For somebody, in the New York market area, for us to get to knock on somebody's front door, between the tolls, the parking, the traffic, the congestion, the madness, it's $200.
Mm,
and you're
that's
going to go
crazy.
change a set of batteries that you don't get paid for.
Right.
Really. I mean, you're not, so, what's the motive? I mean, other than the social construct, what's the motivation to do that? When you talk to somebody outside of our profession and say, oh yeah, I go to that guy's house for free. My plumber who lives 5 blocks away charges me $96 to come to the door.
Boy, that's the dichotomy though, isn't it?
Yep.
Is moral. And I would argue that almost everybody I've met, I don't think I ever have. So I'm saying everybody I've met in our industry so far has some moral fiber and integrity of doing the right thing. And we're in it for the right reason. Right. But at the end of the day, we can't operate if we don't have money coming in. Right.
No, that's correct. Now I put the code
Okay.
in the chat box, and somebody's asking for the code. Can you not see it?
No, I don't see it.
Okay.
Jerry.
Wow, that's weird. Why won't it go? Hold on. No. Nobody. All right, I'm going to read it. Okay. It's WION40. And I would tell you that my vision is a bit of a challenge reading it. The O's could be as zeros. So when you go do the survey, just look for the one that's the closest. Why won't that go? Hold on.
Chad put it in there.
There it goes. I got it.
Jerry, you're in there now.
Yeah. Okay.
Well, again, everybody, thanks for joining us. Any other questions, Jerry, you think, before we hop off?
Hold on. No, there's nothing there, but thanks very much. This was great.
My pleasure. And again, on the decision tree, don't grill me with it. It's obviously a work in progress and can be changed depending upon your practice, but ask if there's a better way, and appreciate you guys all being here. So
you have a future at CMS if it doesn't work out at USGA.
Thanks, Jerry.
Take care.
Take care, everybody.